So this slide shows the mechanism, the schema of fibrinolysis. And I represent an endothelial cell with thrombomodulin and thrombin. Thrombomodulin, you know, it is a major clearing protein for thrombin activity and transforms thrombin to an anticoagulant protein, or almost to an anticoagulant. You will see that it is not totally true. Here you can see the fibrin network and these muscle cells and the extravascular compartment with the intravascular. This slide shows the fibrinolysis activator. You know that the major protein for fibrinolysis is plasmin, which is a plasminogen which is activated to plasmin on the fibrin clot. And this activation occurs through TPA. Plasminogen binds to the fibrin clot through the lysine binding sites, and then it is converted to plasmin through the action of TPA, which also binds to fibrin on the lysine sites. And TPA in turn is cleaved to two-chain TPA, and this enhances the fibrin dissolution. And you can see that there is a loop, because first plasmin starts to cleave fibrin to expose new lysine binding sites, to bind more plasminogen, and then to enhance this process. And urokinase plasminogen activator, which is present at very low levels in blood coagulation, has a synergistic effect with TPA for enhancing the fibrin clot dissolution. But this mechanism is highly regulated. It is what you can observe in the globulin clot lysis time, where fibrinolysis inhibitors are absent and where you concentrate mainly fibrinolysis activators. And you can see here that this mechanism is highly regulated by many fibrinolysis inhibitors, many proteins and systems who have an inhibiting effect on fibrinolysis. First, histidine-rich glycoprotein, which binds to plasminogen and which makes that only a small proportion of plasminogen can bind to this clot. Then there is also TAFI. TAFI is activated by the thrombomodulin thrombin complex, and this TAFI cleaves the lysine binding sites, which decrease the capacity of the fibrin clot to bind plasminogen. So it delays the fibrinolysis activity. Another protein which also delays this is alpha-2 antiplasmin, which is present in fibrin clot. And you know that the very low levels of plasmin which are generated are readily inactivated by alpha-2 antiplasmin, and then they become unable to cleave fibrin. And finally, there is PI1, which will inhibit TPA, but TPA bound on the fibrin clot is protected from PI1 inhibition. And then with time, all the alpha-2 antiplasmin, which is in a limiting concentration respectively to that of plasminogen, it is at a 2 times lower concentration, alpha-2 antiplasmin on the fibrin clot will be consumed, and then more lysine residues will be exposed, which can bind plasminogen, and then the process can start. And this explains why there is this delayed process for fibrinolysis. And finally, during this process, some analytes are generated, fibrin degradation products from the fibrin clot, and D-dimer. D-dimer is, I think, an easy way to express all the different fibrin degradation products which expose the D-dimer epitope. But you can see also plasmin-antiplasmin complexes and TPA or UPA complexes with PI1. This slide shows the clot. You know, the clot is not a fibrin clot, but it is a much more complex clot containing platelets, which can have a contribution for enhancing fibrinolysis, and also many red blood cells. So therefore, fibrinolysis is a highly regulated mechanism in all its functions. And the two major activators are TPA, mainly intravascular, and also extravascular, and UPA with a major role in the extravascular compartment. And there is a strong equilibrium between activators and inhibitors, which allow fibrinolysis doing its life-saving function role. So in intravascular, the activators are TPA with some levels of UPA. The major inhibitor of the activators are PI1, and it is important to remember that TPA and PI1 are at highly variable concentrations in the intra but also extravascular compartment, and they are induced at high concentrations upon stimulation. PI1 is an inhibitor. Plasminogen, it is present at a normal concentration, and it is a proenzyme for plasmin with its inhibitor, alpha-2 antiplasmin. TAFI, which regulates plasminogen binding on the clot, as does with another mechanism, isin-rich glycoprotein. And so the matrix metalloproteinase, mainly MMP9 and MMP2, and their inhibitors, TIMP1 and TIMP2. And you can see less or more the same proteins in the extravascular system, because there is some extravasation of plasminogen and other blood components. And in addition, in the extravascular compartment, you can see neuroserpin, which is a major inhibitor of TPA in brain and on axons. So therefore, in body, fibrinolysis is mainly triggered by TPA, which induce clot dissolution, and then it is therefore a major body defense against thrombosis for allowing recanalization, and we use the capacity of TPA to dissolve clot by activating fibrinolysis in thrombolytic therapy. In the extravascular compartment, fibrinolysis is mainly triggered by UPA and UPA receptor, which focus the fibrinolysis activity, or TPA and annexin 2, which helps to focus the fibrinolytic activity on cells exposing annexin 2. And this also contributes to generate plasmin, and the major role then is to activate the matrix metalloproteinase pathway, which is able to degrade matrix, and it is involved in this matrix degradation, tissue remodeling, or also revascularization, with its major function, as I mentioned already, in cancer, fertility, and cognitive functions of brain. So this slide summarizes the specificity of TPA. In blood circulation, TPA is present at very low concentrations, but in the vicinity of clot, you can find much higher concentrations of TPA, of several orders of magnitude higher concentrations, because TPA release mainly from endothelial cells in the intravascular compartment is released close to this clot. And then when it is bound on the clot, it is protected from PI1 inactivation. PI1 can also be released from endothelial cells at the same time that TPA, and it contributes to block TPA out of the site where it must act on the clot by forming TPA-PI1 complexes. But PI1 is also already present in blood circulation because there are alternative synthesis sites of PI1, and mainly liver. Liver, it is a major site for releasing PI1, and you know that during the anehepatic phase in liver transplant, so there is no release of PI1, and there is a very important concentration of TPA in blood with a highly enhanced fibrinolysis and hyperfibrinolytic syndrome during blood transplantation, liver transplantation in the anehepatic phase. So for pi, it is exactly the same, with the exception that pi comes from liver, but pi1 is also present in platelets in the latent form, and when there is platelet aggregation, additional pi1, from which only 15% is in the active form, is released close to the clot, and it contributes to delay the clot dissolution for allowing healing when there is a vessel injury.